Some older textbooks will say to avoid propofol entirely with a very reduced ejection fraction. And I now know a little bit more that there's some clinical judgment that's involved there than just using lower doses and other medications and all of these things. But it is interesting to look at the dose-dependent cardiac depressant effects of propofol. But another big thing that we do see is also the dose-dependent vasodilation, which then, especially right after induction of general anesthesia, where you've given a large dose of propofol, to be on the lookout for that vasodilation and decrease in the SVR, and then how you're likely to see a drop in blood pressure in relation to that. But one of the biggest things, which I'll hand it back to you, Chrissy, because you do cardiac anesthesia, and I'd be interested to hear your feedback on this, but we definitely learn with very sick hearts to consider dosing separate medications for induction for patients who have like an EF of less than like 25, something like that is what I usually see in the textbooks. What would you have to say about the dose-dependent cardiovascular depression effects of propofol?
It's interesting. If you read about it, I think that it's very nuanced, like everything in life. But yes, you definitely see the drop in SVR. You definitely see a drop in blood pressure. And for patients who are very, very brittle with very severe heart failure, if you give a normal induction dose, you can absolutely kill them. You do not want to do that. Traditional textbook teaching will tell you to switch to etomidate. I think that just switching straight to etomidate is not always the answer, because etomidate also has a lot of really nasty side effects. It has a lot of issues of its own. I think a lot of people really take a more balanced approach where you'll mix several other types of medications for an induction of a patient with severe heart failure. So maybe we'll rely a little bit more heavily on opioids, or maybe we'll do a combined inhaled induction of anesthesia where we're using our inhalational anesthetics through the mask in combination with some opioid like fentanyl, in combination with extremely low doses of propofol. And we'll just take our time and go slow. And we'll just wait and watch the patient go to sleep.